everyone. Welcome to the Emergency Medical Services for Children Innovation and Improvement Center, EIIC, evidence-based brief scientific paper presentation series. Today's topic is pediatric seizures. I'm very excited and pleased to be joined by Dr. Manish Shah, the lead author for an important recent publication related to management of pediatric seizures by paramedics in the field. The article is entitled Multicenter Evaluation of Pre-Hospital Seizure Management in Children. It was published in July of this year in the Pre-Hospital Emergency Care Journal. Dr. Manish Shah is the Chief of Academic Development and Strategy. He's also an Associate Professor in the Department of Pediatrics at Baylor College of Medicine, Texas Children's Hospital. I am the interviewer. My name is Mohsen Saidinejad. I am the Lundquist Institute for Biomedical Innovation at Harbor UCLA Director of Health Services and Outcomes Research Institute, and I hold an academic appointment at UCLA as Professor of Pediatrics and Emergency Medicine. Dr. Shah, thank you so much for your time to discuss this article with us and our learning community at EIIC. And for those of you who are new to EIIC, this is a center of innovation that is created as part of learning resources for various individuals. In this case, it will be pre-hospital personnel and clinicians on various topics, including pediatric seizures. So let's get started. Dr. Shah, my first question for you is, what was the driver for this study? What were you aiming to find out?
Sure, thanks for having me today. And the driver for this study was that seizures are one of the most common reasons why an ambulance is called for a child. And we also know that timely seizure cessation is necessary because seizures beget more seizures if they're not stopped. So ongoing status epilepticus can lead to respiratory failure and neurologic morbidity. And so the stakes are high to manage seizures appropriately in the pre-hospital setting. Unfortunately, we also know from the pre-hospital literature that there's a wide variation in how seizures are managed across the country. And so, however, there is evidence for how to best manage seizures. And in 2014, a team that I was part of created a pediatric pre-hospital evidence-based guideline for seizure management. And in that guideline, one of the main recommendations that we made was to give 0.2 milligrams per kilogram of benzodiazepine either by the intranasal or the intramuscular route as the first line route of medication administration. We know from a single site study that I did here in Houston that these preferred routes were not often given when I did that initial study. And we also know that half of actively seizing patients do not receive midazolam, which is what most EMS agencies use to treat seizures. And even when they do, they get the wrong dose, and it's frequently an underdose. So what we know from all of this as well is that 1/3 of actively seizing children are still seizing upon arrival to the emergency department. So from that single site study, we had many opportunities for improvement that we observed, and it was clear that it was necessary to study with the implementation of the evidence-based guideline, does care improve? And so the purpose of the study was to compare management of the pediatric pre-hospital seizures in 3 EMS agencies to determine if significant changes in practice occurred after these systems implemented protocols that were based on the evidence-based guideline. And so that's why we did the study.
Excellent. Thank you so much. I think you kind of touched upon this already, but can you tell us a little bit more about how you determined how to design this current study and who would be included in that study?
Sure. My co-investigators and I conceived the idea for the study after the evidence-based guideline had already been implemented in these 3 systems. So it is a before and after comparison. And so though there are limitations with a design like that, we knew that gathering this information from these 3 EMS agencies would be helpful to inform ongoing needs for improvement in pediatric seizure management that could be studied in a larger prospective study. And so the sites that were involved in the study were those from the Charlotte, Houston, and Milwaukee pre-hospital research node of the Pediatric Emergency Care Applied Research Network. And the reason we chose those 3 sites was with the intent that we would be planning a larger prospective study to address areas of needed improvement in the future.
Excellent. In this article, you mentioned something called grade evidence, all capitals, GRADE. Can you briefly describe what grade evidence means?
Sure. Grade is a process of evaluating the quality of evidence that exists in the published literature, and then using that to apply it to the development of an evidence-based guideline. So I mentioned that 2014 publication that we had, that was a joint collaboration between the National Highway Traffic Safety Administration and the Emergency Medical Services for Children program to use a novel model process to use grade in the creation of evidence-based guidelines specifically for pre-hospital care.
Okay, excellent. So I noticed you had talked about this algorithm that you had created. I actually putting up here for our viewers to see, and you had mentioned that this was in the 2014 paper. It also shows up in this article as well, but you did mention that there is some changes that you're considering making after some of the feedback that you've received and some of the other information related to this. If you don't mind, just tell us briefly about this algorithm that shows up in the paper and what modification would you anticipate needing to be made to this algorithm to be more up to date?
Absolutely. So when you create an evidence-based guideline, you have to use the evidence that's available at that point in time. And so this guideline was actually, the process of creating this guideline began in 2009 and actually took several years. So we weren't finished until 2012. And then the actual publication happened in 2014. So that's important to remember when people look at this algorithm, is that it's based on evidence that existed from 2012 and prior. And so at that time, there were things that we knew and there were things that we didn't know. Things that we knew were that giving a benzodiazepine by a route other than IV is important. And one of the key pieces of evidence that we used for that was that there was a randomized trial that included both adults and pediatrics that is well known, called the Rampart trial, where they demonstrated that seizures stopped faster in patients who received intramuscular midazolam when compared to IV lorazepam. And so as part of this algorithm, we recommended giving non-IV routes as first-line agents. And so there were other studies that we had found when we created this algorithm that looked at the use of intranasal benzodiazepines and also looked at buccal benzodiazepines. Now, the buccal route is not used in the United States. It's frequently used in other areas of the world. And so, but we did include that in the guideline. Also, we don't discriminate between different types of benzodiazepines in the guideline. We note that you can give midazolam, lorazepam, or diazepam, but if you're truly trying to give intranasal or intramuscular benzodiazepine, and knowing what we know about EMS agencies in this country and their practice, midazolam is the preferred agent that's used by the majority of EMS agencies in this country. But one other nuance of difference is one of the things that we didn't know when we created this guideline is we didn't know how frequently actively seizing children had hypoglycemia. And so what we do have discovered from several studies, both our study that we published this year and other studies in other EMS agencies, is that the prevalence of hypoglycemia in the setting of actively seizing children is quite rare. And it's in the literature, it's anywhere from 0.5% to 2%. So because it's that rare, I would revise this algorithm now to make checking a blood glucose a secondary priority. That algorithm recommends doing it as a first step, but instead in 2020, I would say that really the main priority should be getting the midazolam on board as quickly as possible. And then if there's still an ongoing seizure happening 5 minutes after that medication has been given, then checking a blood glucose to identify potential hypoglycemia should be done.
Okay. How do you engage the EMS agencies that participated in this to actually participate?
Sure. So I mentioned the Charlotte, Houston, and Milwaukee pre-hospital node of PCARN, they're the CHAMP node. That CHAMP node has existed since 2013. And when we created that CHAMP node, part of the structure of it is that we wanted to integrate the inclusion of field emergency medical technicians and paramedics to provide input on research ideas that we were developing within the node. And so our structure is that we have representation from field providers from Mecklenburg County EMS in Charlotte, the Houston Fire Department EMS system, obviously in Houston, and Milwaukee County EMS in Milwaukee. And so we have those 5 EMTs and paramedics at each of those sites provide input on both this study that we did and other studies that we have done since 2013.
Excellent. Thank you so much. So let's sum up your findings. You mentioned about medication administration, glucose monitoring, IV access, assessment, and things like that. Do you mind just giving us a brief summary of the paper in general?
Sure. So when it came to medication administration, I think there are several important observations that we made when comparing before and after implementation of a protocol that was based on this evidence-based guideline. So after protocol implementation, we know that paramedics were more likely to administer midazolam to actively seizing children with an increase from 61% to 71%. So that's fantastic. However, what we also know from that is that there's still room for improvement. There were 29% of the patients were still not receiving the midazolam. And when you look at those who did receive the midazolam, half of them got an incorrect dose, with the majority of those, about 70%, being underdosed. What we also know is that paramedics were more likely to administer midazolam via the intranasal or the intramuscular routes after protocol administration. So there was an increase from 49% prior to implementation of the protocol to 77%. So that increase is remarkable, but again, there's still room for improvement. It's not 100%. We also know that it takes approximately 14 minutes from the time of paramedic arrival on scene to administer that first dose of midazolam to the patient. And this did not change pre versus post protocol implementation. So this also tells us that improving the timeliness of medication administration is a potential opportunity for improvement because, like I mentioned earlier, seizures beget more seizures. So if we can stop that seizure earlier, then there's the potential that that child will not arrive to the emergency department still seizing. We know that from this study that unfortunately, approximately 1/3 of the patients were still seizing on emergency department arrival, and there was no difference before or after protocol implementation. Like I mentioned earlier, we know that hypoglycemia is rare. So in our study with these 3 sites, we observed that only 1% of actively seizing patients were hypoglycemic.
So should the pre-hospital personnel do glucose monitoring at all?
Well, I do think that there is a role for glucose monitoring, but really the priority should be on administering that first dose of midazolam by the intranasal or intramuscular route. And only if the seizure continues should the glucose be checked at that point.
And what is your thoughts about consideration for IV access? What kind of priority do you give that?
Sure. So we actually recommended in the evidence-based guideline that we published in 2014 to not obtain IV access. We know that it is challenging to obtain an IV in children. It's even more challenging in the setting of being in the back of a moving vehicle to try to obtain access. And really, because we know from other research that giving an intramuscular medication like midazolam actually can achieve seizure cessation quicker. And although there hasn't been a direct head-to-head comparison with intranasal and IV, based on the current evidence, it seems like that may be a reasonable alternative to administer the medication. So that's why we recommend giving intramuscular or intranasal.
Great. Can you also briefly mention about respiratory failure and what to expect when you're giving doses of benzodiazepine in the field?
Sure. In our study with these 3 sites, we observed that about 17% of patients had respiratory failure. Now, it's important to point out what the potential cause of the respiratory failure is. Respiratory failure could happen if too much benzodiazepines are given. And what we know when we created the evidence-based guideline is that it was only when patients received more than 2 doses of benzodiazepine that there was a significantly higher risk of respiratory failure. And so for that reason, we recommended in the evidence-based guideline that paramedics should have the ability to give up to 2 doses of benzodiazepines without the need for additional approval to give it, because the risk of having respiratory failure strictly from the benzodiazepine is low. However, we also know that when you have an ongoing seizure, there is a risk for respiratory failure. So although it's unclear what the underlying cause of the respiratory failure is from our study, we do know that ongoing seizures contribute to respiratory failure. And so our hope is that by improving timeliness of medication delivery and by giving the optimal dose, that the rate of respiratory failure decreases.
Right. So with the proper dose, not only that you are doing a great job with seizure stoppage before the patient arrives to the ED, but you also avoid overdosing and causing respiratory failure.
Correct.
Great. So just to wrap up here, what are the important take-home lessons that you would have for this study for our learners to be aware of?
So I think there's a few. I think it's clear from our study that implementing a protocol that's based on this evidence-based guideline is associated with both increased administration of midazolam and increased administration by the preferred intramuscular intranasal routes. However, despite this, we know that from our data from this study that there's ongoing opportunity for improvement to enhance the timeliness of medication delivery and also to provide a correct dose because most of these patients that are getting midazolam are getting underdosed. I think apart from this study, what we do know from another qualitative study that we did in these 3 EMS systems, we learned from paramedics that the need for calculating a dose is a barrier to administering the medication in a timely manner. And this is a stressful situation for them. They are dealing with a critically ill child where there's bystanders there, and then they have to do math to figure out a correct dose. So it's no surprise that that errors can be made in calculating the dose under such a stressful situation. And so what we learned from our qualitative study that we published last year is that if there's a way to eliminate the need for the calculation, that might improve the accuracy of the dose and also the timeliness of administration as well. And so we've actually submitted a grant to the NIH to study this in the PCAR network, to study standardized age-based dosing of midazolam as a potential strategy to improve seizure cessation prior to ED arrival.
Awesome. Thank you so much, Dr. Shah. Really appreciate all your time and your expertise that you're lending us here. For more information similar to this and our other educational resources, please visit us at our Emergency Medical Services for Children Innovation and Improvement Center, https://emsimprovement.center, or follow us on Twitter. Thank you again, Dr. Shah. Really appreciate it.
Thank you for having me today.